And at that time, people used to always think that pediatric endocrinology is one branch, which is basically very, very rare, dealing with rare, complicated disorder, which require cumbersome evaluation and expensive treatment. This was a common thing. Everybody used to say, what will pediatric endocrinology do? Nothing much to be done at this there. But when we started seeing patients, we were shocked by the way they were being managed. And this is one case with Dr. Rashmi and both of us managed. It was a very short child, diagnosed in 10 years with severe anemia, presented for the first time. And then at that point of time, there was a short stature and was given a blood transfusion, diagnosed as a case of celiac disease, but unfortunately had developed HIV because of the blood transfusion which happened in that scenario. So this was an unfortunate scenario, a case which should have been diagnosed at the right time and should have been managed in that perspective or missed in that scenario. So we thought, what are the problem? Is it a problem of awareness, accessibility, or affordability? Now everybody says it is always a problem of cost. So people say cost is a major problem. But what is the truth is actually the elephant of the house is awareness. If you don't know when should you go, where should you go, how you should be managed, it is difficult. Once you go, direction is there, people will help you. People will help the patient will help themselves, but most important is awareness. So from there, we started our program, and 2012, we had the first PPEC, and a lot of people here, including all the seniors, Dr. Subrato, Dr. Rishi, everybody was part of that program. And since then, we have conducted huge number of programs across the region in the country. But unfortunately, how many physical programs one can do, that is a limit to that. So we started the advanced programs as well. So we moved forward from there to internet media, because now internet is available. So we started on YouTube around 7 years ago. And from there, we moved forward towards a structured program, both on-site as well as online. And now we have got the application and other things which are happening. We have e-learning program, which has got huge number of subscribers, and all of you would have accessed that. This would be something to go forward. But problem with YouTube is that you can see one video and then you forget about it. So if you want to have a systematic learning, we started off with this program of Medi classes 4 years ago, in which we now have a fellowship program and a diploma program. A lot of programs are there. A lot of people are part of that program as well. Now, we also run regular postgraduate fellow classes, and the publications and applications are there. Applications are going to make very easy day-to-day management in that regards. The often problem which still remains is that the number of pediatric endocrinologists in the country may be around 100, and 100 may be an overrating, exaggeration. Cases are thousands. So what do we need to do? There needs to be a bridge between cases, pediatricians, and pediatricians with special interest, and then more pediatric endocrinologists. This is what we are looking at. For that, now we are trying to come up with a solution, which hopefully will come up in the next 2 to 3 months, which will help you out using a personalized, intelligent EMR. So what it will do is that based upon your particular problem, so if a child has short stature, once you say short stature, specific questions will come with regards to history, examination. This will be there for all conditions. So precocious puberty, delayed puberty, DSD, whatever, 40 conditions we are developing these protocols. You just have to enter these data. Once you enter, you will ask specific questions in examination. So for a delayed puberty, it will ask anosmia. For precocious puberty, it will ask about headache. So different questions will come. Once you answer those questions, put basic data while you are examining the patient. This is looking very benign, simple. You're just putting. But what is, and you can simultaneously assess bone age there. So it looks very simple, you're doing that. But what is happening is that behind the scene, algorithms are running, which are then telling you this is the diagnosis. This is the investigations required. This is the likely treatment. And then you will get a lot of output. And you can then export it in the form of a proper, it will give you like a proper history has been taken. You will get results, interpretation. This is a work in progress. A lot of intelligent algorithms required. It will take time, but this is the way forward. So this will allow everywhere across the country to have a state-of-the-art, quality assured sort of a management, and then there could be connections with clinics as well. So this is something which we are working in that direction. Last 3 days, we had very intense program in the Regency Center for Diabetes, Endocrinology and Research. Over 30 people from across the country had come, and it was a very good interaction with over 300 cases in which a lot of interactive discussions.
Till now, we have been thinking that osteoporosis is a disease of adults, and we generally do not encounter this condition in pediatrics. But to our amaze, It is also a pediatric condition, but it differs from adults not only in the management, but also in the definition and diagnostic modalities. So before moving ahead with the latest therapeutics in the management of low bone mass in pediatrics, the first question that arises is who are the actual candidates who need this treatment? So International Society of Clinical Densitometry has very clearly pointed out in the year 2013 that all those children who have vertebral compression fracture with or without a BMD Z score of less than -2, and yesterday we all have gone in detail about the BMD Z scores, or a BMD Z score less than -2 with a history of long bone fracture. In this long bone fracture, there should be a frequency of more than 2 long bone fractures in a child less than 10 years of age and more than 3 long bone fractures in a child less than 18 years of age. So if you have a vertebral compression fracture, that alone is sufficient to start therapy in such a child. But if you have a low BMD Z score, then a clinical history of pathological fracture is important. So why does this low bone mass occur in individuals or children? So yesterday we have gone through this variation in the bone mineral density across the lifespan. And if we further dissect the first 20 years of life, then what we analyze that the peak height velocity is attained nearly a couple of years prior to the peak bone mineral density. So what does that mean clinically? That during the adolescent or the pubertal phase, although the bones are elongating, but they are not accruating the bone mineral density. So you have longer but weaker bones. And such children are at higher risk of pathological fractures. And studies have found that adolescent males are at a higher risk of fracture as compared to adolescent females. And this could be attributed to their general intensity of going out, being physically active, or having a low estrogen level as compared to the females. Apart from this adolescent phase of low bone mass, there are a number of primary and secondary acquired conditions which are responsible for decreasing the bone mineral density. And all these conditions directly or indirectly cause an alteration in the bone remodeling process, which you would have already studied in the bone physiology class. So these conditions lead to an increase in bone resorption compared to bone formation, leading to a decrease in bone mineral density. So taking advantage of this physiology, the available therapeutic options which are available fall into 3 categories, which are anti-resorptive, among which we have bisphosphonates as the prototype of being anti-resorptive agents, followed by SERMs, calcitonin, denosumab. The second category is anabolics or the bone forming agents, among which the recombinant parathyroid hormone is the prototype. And there is a new class of drug coming up, which is a sclerostin inhibitor or the Denosumab, which has a dual action. But what is surprising is that none of these agents are approved by FDA for use in pediatric osteoporosis. So what do we do next? So these are the latest guidelines which are published in Pediatric Rheumatology in the year 2020 for the diagnosis, assessment, management, and monitoring of pediatric osteoporosis, which tells us that calcium and vitamin D supplementation form the backbone of managing pediatric osteoporosis. And although FDA does not recommend use of bisphosphonate, but bisphosphonates can be used, because for the last 30 years, we have experience in using bisphosphonate for pediatric osteoporosis without any long-term side effects. So our talk will be focused on bisphosphonates because these are the therapies which are recommended or which are in constant use in pediatrics. So bisphosphonates are basically pyrophosphate analogs, and among this, what we see in the molecule is that the phosphate carbon phosphate lineage is responsible for the affinity to the bone tissues. So there are 2 side chains, the R1 and the R2, and this is the R1 which is responsible for the affinity to bone tissue, while the R2 is responsible for categorizing bisphosphonate into nitrogenous bisphosphonate or the non-nitrogenous. Both the categories ultimately lead to apoptosis of osteoclast, which is the main cell type responsible for resorption. They have a fundamental difference in the mechanism of action. So generalizing, we have bisphosphonate acting as the anti-resorptive agents which bind to hydroxyapatite crystals in bone, directly or indirectly inhibit the osteoclast, and they are pharmacologically active only on the exposed bone surface, and they are bound to the bone for years to come. So, but this anti-resorptive property of bisphosphonate could not explain the fracture rate incidence which was getting reduced in using bisphosphonate. So studies were done to further elucidate the mechanism of action of bisphosphonate, and it was found that along with the anti-resorptive decreasing capacity, bisphosphonate also potentiated the life of osteoblast and osteocytes. Osteocyte, as we know, are the mature osteoblasts. So this property was responsible for causing a reduction in the fracture rate in children who were treated on bisphosphonate. So this graph shows a general relative resorptive potency among the older and the newer generation bisphosphonate, and it can be clearly seen that zoledronic acid, which is a newer agent, has comparatively better anti-resorptive potency as compared to the older molecules, which is etidronate or pamidronate. Coming on to now, we know that bisphosphonate are the agents of choice to be used in pediatrics. The next question that arises is what dose should be used, how frequently we should use. But as I told, there are no FDA recommendations for the use of bisphosphonate, so we do not have any recommendations on the dosing as well. But because of the studies that have been conducted across the world, these are the general doses that we follow. So these are easily available in the Pediatric Rheumatology 2020 guidelines, so we'll not spend much time going through this crowded table. Next, we will come that there are two routes of administration of bisphosphonate, oral versus intravenous. So once we have decided that we have to use bisphosphonate, the next question comes is, should we go for oral or intravenous? So this was a Cochrane study which was published around 5 years back in 2016. It included 14 trials with 819 participants, but among these 14 trials, only 4 trials had a head-to-head comparison of oral versus IV bisphosphonate. And although we have a limited data, it showed that there was no difference in the acquisition or improvement in BMD among the oral or the intravenous bisphosphonate. But because the experience is more with IV bisphosphonate among children, so it is preferred to use IV in children. The only indication for using oral is mild osteoporosis with no vertebral fractures, or if there is a clear-cut contraindication for using IV bisphosphonate. So just to break the monotony, these are some radiological images acquired from children who are on bisphosphonate therapy. So you can see on the radiological images, there are some sclerotic bands present in the metaphyseal regions, and these are known as the zebra lines. These are the periods of inhibited osteoclast activity during the growth phase. They have no negative effect on the growth potential of the child, and they disappear as the bone moves towards the diaphysis. So how long to give the therapy? So ideally speaking, again, there are no set recommendations of how long to use, but as a thumb rule, it should be used till the BMD Z score improves above -2. So no drug is associated without adverse effects. So bisphosphonate is also associated with some acute and long-term complications. So among the acute adverse effects, we have the flu-like illness, which can be avoided by giving either a paracetamol 24 hours before or covering paracetamol infusion 24 to 48 hours after bisphosphonate. Then we have the risk of hypocalcemia, which can be decreased if we maintain a sufficient vitamin D level above 50 nanomoles or less than 30 nanograms. And then there are long-term side effects of osteonecrosis of jaw and atypical femur fracture, although no pediatric cases have been reported so far. There were some doubts regarding atypical femoral fracture in bisphosphonate treated patients among osteogenesis imperfecta, but studies have clearly found that it was not due to the usage of bisphosphonate, but was due to the underlying OI severity. So should we use bisphosphonate routinely was the next question that was answered beautifully by this study. We stated that it needs to be assessed on the basis of the underlying clinical condition leading to the low bone mass. So if we have a condition which is of transient and it has increased chances of recovery of low bone mass, and one can wait for BP therapy. But if there is a permanent condition like a neuromuscular disorder in which there is no chance of increase in LBM, then one needs to counsel the patient for BP therapy. The other molecule in pipeline is the rank ligand inhibitor, but because we are not using it routinely, so we will not spend much time on this. Just to touch base, it is a rank ligand inhibitor. It also inhibits bone resorption. It has to be used for a period of 2 years. The dosage are 60 to 120 mg, administered subcutaneously 6 monthly. The available brands are Prolia and Extiva. It has a rebound bone resorption once the molecule is stopped, and thereby there is a risk of hypercalcemia and hypercalciuria. Because there are no long-term studies using this molecule, so pediatric usage is limited. So there are isolated case reports using Denosumab, which have shown that the usage beyond 2 years have no improvement in BMD. So usage till 2 years is recommended, and after which bisphosphonate therapy should be used to avoid rebound resorption. So after these are the available literature. Anabolic agents are still in pipeline, not much recommended. PTH hormone, although used in adults, is associated with risk of osteosarcoma in children because of the growth potential. So these are also not used. Anti-sclerostin molecule is under trial. There are some clinical studies going on. So maybe in the next session, we can have a look on it. So take home messages from this slide is that calcium vitamin D supplementation is still the backbone of low bone mass therapy in children. Bisphosphonate should be used only when clinically indicated, and routine clinical, radiological, and analytical monitoring should be done along with BP therapy. So these are the papers which you can use for further reading if interested. Thank you.
Thanks, Neha, for really summarizing in just 10 minutes.